good evening. This is Medical Dialogues Present Health Perspective, and I am Dr. Rohan Krishnan. In today's episode of Health Perspective, we are going to talk about a very serious topic which is less listened to, less heard of, even in the medical community. This is the right to access mental health care law in India. As per our knowledge, every person in India shall have a right to access mental health care and treatment from mental health services run or funded by the appropriate government. The right to access mental health care and treatment shall mean mental health care services of affordable cost, of good quality, available in sufficient quantity, accessible geographically, without discrimination on the basis of gender, sex, sexual orientation, religion, culture, caste, social or political benefits, class, disability, or any other basis, and provided in a manner that is acceptable to persons with mental illness and their families and caregivers. The appropriate government shall make sufficient provision as may be necessary for a range of services required by persons of mental health illness. To discuss more about this topic, we wanted to invite someone who is having more knowledge towards the mental health care law and who has been well versed and experienced of more than 35 to 40 years in the Department of Psychiatry. Give me the pleasure of welcoming Dr. Nimesh Desai, sir, who is a well renowned psychiatrist in India, who is one of our guide of all the youngsters, and he holds the position of being the former director of Institute of Behavior Health and Applied Sciences. Welcome, sir. Welcome to today's
Hello,
episode of.
Rohan. How are you?
I'm fine, sir.
Always good to be with you and friends.
Thank you so much, sir, for giving your precious time to us and guide us towards the
Anytime.
mental health bill. Sir, what is this
Anytime.
mental health care bill, mental health care law in India? What is it all about?
See, very briefly, as you and youngsters will know, mental health has been governed by law much more than the general health care. Way back in 1858, there was the Mental Asylums Act. Okay, soon after the British Crown took over from the East India Company. Then there was the India Indemnity Act in 1912. These were mostly about mental hospitals and mental asylums. The 1987 Indian Mental Health Act broadened the idea a little bit, but the most recent law, the fourth one in India, 2017 Mental Health Care Act, which was implemented from 2018. So now we have had nearly 5 years of its implementation experience, is actually very progressive. Many people believe and say far too ambitious, in fact. So, like you were mentioning so well, the Section 18 of Mental Health Care Act 2017 provides for right to access mental health care. Let's remind our young colleagues that right to health care is still not legally justiciable in this country, except of course this very recent Rajasthan provision. But in the National Health Policy of 2017, one of the guiding principles is to try and get ensure right to health care. And of course, the program goal of universal health coverage from UN and WHO remains, right? But for last 5 years, we have actually had a legally provided right to access mental health care provision in this country. Was also saying, in addition to what you said so well, Rohan, that the Mental Health Care Act 2017 also defines what is mental health care. So, as many of us might think, and let's accept, in this country, a lot of shortcuts happen. That if people are taken to treatment once and treatment initiated, that be the end of it. That's actually not permissible. Mental Health Care Act 2017 actually defines mental health care as complete spectrum from initial assessment, diagnosis, treatment to rehab. As you and our other friends will appreciate, in many mental health problems, especially long-term mental health problems like schizophrenia, the rehab needs are very strong and very long-lasting, if not lifetime. And so, actually, this provision, in addition to many good points that you made, one, it covers the entire spectrum. So, no state government or central government can escape the duty to provide not only acute treatment but long-term care, including rehab. And as I was reading through the section 18 again, it's very interesting. The Act actually even provides for saying nobody should travel long distances to be able to access mental health care. There should be affordable, accessible mental health care in every district. Of course, the good news is that by now, as per Government of India's National Mental Health Program, there is a mental health program in every district. One must say, slightly guardedly, at least on paper, in theory. Uh, in many places, perhaps it's not very functional, but in principle, on paper, district mental health program does exist in every district. And just one more thing before we get to the other issues, Ron. Like you mentioned obliquely, this act actually even says that, and that's really ambitious. I don't know how it's going to turn out. That if a person with mental health problem cannot get government funded mental health service, he or she can avail of it from private sector and get the bill reimbursed from the state government. Okay, it's as far as that. And of course, it provides for, which is very important to us in mental health care. Many of you will appreciate the private health insurance, or indeed the government health insurance like Ayushman Bharat or any other by any state, must also have same facilities for mental health as is available for physical health. So, in addition to the basic provisions, there are two very good provisions. We'll have to see how it works out. One, that if you do not get service in public sector, you can actually go ahead and get it in the private sector and get it reimbursed. And two, health insurance scheme should be at par for mental health as compared to physical health. But from what I know, as compared to the Rajasthan Right to Health Bill, this mental health care law is reasonably stabilized in one sense. It places the primary responsibility for providing mental health care on the public sector, the government funded public mental health establishments and public health establishments. So, as far as I have understood about the Rajasthan bill or the act as of now, they might have one or two good lessons to pick up from this act, and make sure that for those who cannot afford, the lower middle class or the marginalized populations, the responsibility should be with the public health establishments and not necessarily with the private sector, except for emergencies, of course.
Sir, but on ground level, how much is this Mental Health Act right now functional? Because as per my knowledge, I've seen that those people who are not getting mental treatment in the rural setup are being charged exorbitantly in the private sector. And at the end of the day, it is very difficult for the family to bear the cost because mental illnesses takes longer period for
Long
the
time.
treatment.
That's true. That's
And the treatment nowadays are getting costlier also. So you have
correct.
worked in one of the topmost institute of the country where everything was there at subsidized rate. But I
I
don't know,
know.
as per my
That's true.
knowledge, it is not available to the lower middle class or the actual poor people of the country.
The difficulty there, Rohan, may be twofold. And let's address the first issue that you are talking about a little bit in detail. See, and that's why remember I said that on paper, in theory, the district mental health program does exist in all the 700 and odd districts of this country. Okay. In reality, how much does it really operate on the ground is a good question. Maybe in some districts it's still lacking. There is also the linked problem of availability of mental health resource, qualified psychiatrists, psychologists, psychiatric social workers. Also, as you said, quality of the availability of medicines and the other treatment methods. But I must say, Rohan, and I've been involved in this quite a bit on behalf of Government of India, not just Government of Delhi, but Government of India and the NHRC. It's happening. The availability of affordable, accessible mental health care in this country, I would say, is happening. Now, what I must point out is what I have seen for all these 40 years, and you and your colleagues have seen. If I am from one of those socioeconomic strata who cannot afford to go to the private sector, and I go to the public sector, then obviously there will be this whole issue in this country of crowds and long lines and sometimes availability and sometimes non-availability of medicine, all around. No denying that part. Now, that dream scenario in actual practice, when will we reach, is still a good question. But my cautious sense, Rohan, is what I mentioned will be a good idea. Private health insurance. See, for good or bad, and it's a mixed debate. For good or bad, we are following, please consider, we are following the American system of mixed delivery of public and private sector. Payer chooses wherever I want to go. I can get up from Trivandrum and go to AIMS Delhi or PGI Chandigarh or even to an institute in Tejpur, and somebody from Jorhat can come to the institution in Ahmedabad or Thane, right? That's the system that we are following, unlike Australia, New Zealand, England, Canada, where there is the large public sector, government controlled and sectorized. Okay. So we are following the American system, where again the next step that we are following is the health insurance. Some private funded, large part, hopefully, it's already beginning to happen. It will happen more government funded, central government or state government funded, like the Ayushman Bharat. So, what is really nice, if it can be implemented sincerely, is provision of mental health care service in the insurance schemes, both private that I might buy with premium or the government provides for me. You will appreciate, and a lot of our friends will appreciate, your generation is a lot better, not just in our medical colleagues, but in general in the society, about there being less stigma of mental illness. But let's face it, overall in the society, in most sectors, including policymakers, wherever they are sitting, including insurance companies, there is a huge stigma of mental health problems. Okay. And so this is still a hurdle to be overcome. That provision of mental health schemes in government and private funded health insurance schemes. When that happens, hopefully what you are saying will be much easier. But let's face it, I must also mention, I'm not just a psychiatrist and with some experience, I'm also a public health qualified person, and I have spent some time in the US understanding their public health system. The uninsured, as some of you might remember from your own experience, God forbid, or if your family members have been to the US and if they did not have health insurance and ran into any physical or mental problem, God help them. To be health uninsured in a system that is predominantly on health insurance is a nightmare, one. Two, there is a delicate issue that most people, including my own colleagues, I must say, don't realize. And I've actually seen this happen. Health insurance companies and what is now called HMOs, health management organizations in the US. Over time, what will happen is it is those companies and HMOs who will control the clinical decisions. Okay, so the clinical decisions will not be with the cinemas clinician in charge of the team. So if there is a scheme for, let us say, 21 days admission for alcoholism, right, or 7 days admission for depression with suicide risk, the insurance company, if I am the insurance guy, I'll come and tell you the chief clinician and say, Doc, 8th day morning, he must be discharged, regardless of what is your clinical impression. Or the person must stay from his or her own pocket, somebody must pay. Now, this is another nightmare that I do anticipate. Hopefully we will find some solutions to it, but the American health system also does not have solutions for these problems. So if we, like you and I are both concerned, and many of us, if you really want in substance, not just in principle, not just on paper, like you're saying, on ground reality, equitable, fair, clinically managed healthcare or mental health care, that's going to be a tough call. I have no doubt in my mind about that. Must say, in a lighter vein, Rohan, and none of you should misunderstand this. I genuinely believe that 25 years from now, when we complete 100 years, will be much better when all of you will be at the peak of your careers, by 2047. And I do sincerely believe and hope so. But let's face it, till now, our history as a nation, as a society has been what we often say in our drawing rooms or parties. We have very good laws. The only difficulty is in implementing them. Okay, हमारे देश में कानून तो बहुत अच्छे बन जाते हैं और कानून बहुत अच्छे हैं भी, लेकिन उनका अमल कितना हो पाता है ये सवाल उठ रहा है. Must also say that last 10 or 15 years gradually we are getting better there. We have huge lot of population issues, logistics, like you said, affordability, all of that stuff. But I think we are getting there. And so I have a very middle of the road position about. In fact, initially I must say this act I used to find very very ambitious and unrealistic, like many of my secretary colleagues. But I have understood and I've been explained and I have understood and studied more. See, what Mental Health Care Act 2017 conveys is the legislative intent. Parliament's aspiration and intent to say this is where we want to reach. Now it is for all of us, and of course your generations to decide. Medical doctors, policy makers, parliamentarians to say, uh, do we want our laws to be aspirational or do we want our laws to be realistic? Please be sure there are problems in laws being aspirational, because once it's codified in law, it is justiciable. You see, anybody can go and question it in a court of law and say, look, I should get this so and so, but I'm not getting it. Now, how that scenario will unfold, nobody knows even after 5 years of this implementation of this act. But there is the to summarize again, there is the intent. There is a fair bit of program network in place to be improved and strengthened much more. There is fair amount of implementation, and yet a lot more needs to be done, especially in the area of good management of public health systems and health insurance schemes. What will remain, Rohan, and all of you young colleagues must, I sincerely plead for a minute or two to keep this also on the radar. Switching gears, depression, anxiety, phobia, OCD, what was called neurotic conditions where I realize and accept that I want help, easily manageable. It's only a question of setting the systems in place, right? The difficulty, my friend, in 21st century mental health care service delivery is already and is going to be much worse. The interlocking arrangements between right to access mental health care versus right as persons with disability. Okay, including as some countries have right to refuse care. Okay, some countries already have. Fortunately, we haven't followed that. So if I have paranoid schizophrenia, or if I have mania, and if I decide in my best judgment I don't want treatment, it's not impossible for you or the mental health team to get me into treatment, but it involves a whole lot of legal processes, and fairly so, because there is the temporary suspension of my right as an individual for you or the state to force treatment on me. Okay, coercive or involuntary treatment. So that's going to be a problem. And very briefly, some of you might remember, I have this huge concern, and for 20 odd years, we've been working from us as well as some NGOs in Delhi and outside on homeless mentally ill people. See, those people who you see in all cities and towns in Delhi, Delight Cinema, Asaf Road, Nizamuddin, Jama Masjid, people with schizophrenia who have nobody to look after them, they are on the street with subhuman existence. Now, that's another area that's a major concern. Because in trying to assert the rights-based model, providing rights to everyone, including persons with mental illness, you and my other friends, please appreciate, because somewhere in your lifetime and career, you will directly or indirectly, at least as citizens, as friends, God forbid, as family members or policymakers, you'll have to deal with this. That's a very soft, vexed issue. Besides making the management stronger and making sure that services reach. Does any country have very good answers to that? No. Different countries have different solutions to the second part that I'm talking about. The almost contradictory, if not antagonistic and contradictory interface between right as a person and access to healthcare. You see, the thing, Rohan, is that, like some of you will appreciate, if I'm in, and this is what really bothers many of our psychiatric colleagues, and I can understand how they feel. See, if I happen to have diabetes mellitus, if I go into ketoacidotic or hypoglycemic coma, or if I have bronchial asthma, I go into a serious crisis, or if I have a heart condition and I go into a cardiac state, You or the family members, you as my friends, can easily take me to the hospital. There isn't the whole issue of getting my consent. Although in theory, please realize that can also happen. I can refuse treatment for my diabetes mellitus. I can refuse to go to a hospital even if I'm getting sleeping into a coma, right? But in actual practice, that doesn't happen. In psychiatry and mental health, unfortunately, because there has been a long-term history of societal as well as mental health system-based violation of human rights, and people were maltreated, abused, treatment forced on them, correct or incorrect. Unfortunately, this rights-based model has been applied much more strongly. So a person with schizophrenia or a person with depression with suicide risk can actually refuse treatment and say,
Sir,
sorry, doc, I don't want treatment.
yes, sir. But one thing, sir, which I want to ask, sir, this, as you rightly said, that any law which has been passed, it should we have to decide that it is it aspirational or it is practical. I think that these are the words of
Hmm.
wisdom which I took from today, because it feels applicable in the Right to Health Bill of Rajasthan as well. That once it becomes a law, it has to be
Yeah,
justifiable. So it should be aspirational or it should be practical for the healthcare workers.
yeah.
Sir,
And the second
in
part is the private sector cannot be burdened primarily with the responsibility that public sector must carry. You
obviously,
see,
otherwise
as you
there is
know, I've worked in public sector for 40 years. I'm now kind of retired and moved out. But I've always respected both sectors for what they do for the society. You know,
uh, exactly.
so those are
So,
the
sir,
main issues. Sure.
one thing that comes to my mind, sir, if suppose there is if this program is applicable in every district, who is the head of the program in the district level, and what if some of
And
our viewers who want to get help in remote
sure.
areas, someone in Karnataka wants to
Sure.
get help, what should he do?
Very good question. Very good question. Those. See, one is there is in the district mental health program is supposed to be managed at the district hospital. So the civil surgeon or the chief of the district hospital is where somebody must contact. The second, for now that the Act provides not only for the rights-based issues or possible violation, but also for access to mental health care as per this law, there is supposed to be in every state what is called, Rohan, my friend, state mental health authority. Okay, that existed in the 87 Act also. In the new Act also, there is supposed to be a state mental health authority, and of course, there is a state authority. State mental health authority is for good or bad. Okay, there can be always pluses and minuses. SMHA in every state by law is supposed to be chaired by the senior person in the health department. Principal secretary health of each state will be the chairman of the SA, and members will be from NGOs, psychiatrists, social workers, and of course, member secretary most of also is supposed to be the psychiatrist in the state medical college or the state mental health institution. Okay, so for example, for last 15 or 17 years out of the 23 years that I spent at Delhi, I looked after the SMHA in Delhi, old act as well as the new act. And I must say, in a lighter way, I mean, the government changed in 14 and 15, as we all remember. But having been part of the system and the interesting developments as I saw, we had ensured, again, can't say it was foolproof, but to the extent possible, by 2010 or 2012, that all districts of Delhi had mental health services available besides the hospitals and private sector, and nobody should have to travel more than 5 or 10 kilometers. But to repeat what you and I both said, one, this does not take care of the ground level implementation issues that anyway is a common experience in our country. Okay, education, health, welfare, whatever, and the legal issues for those who don't want to be treated. Those two major themes remain. How do you ensure that whatever is the program actually should happen? Let me also briefly mention something else, especially for Delhi and Delhi, if at all, and other states, I'm sure will follow. For people who do not accept that they need treatment, either homeless or you and your friends will appreciate, there is often a lot of people with schizophrenia, with depression, with mania who are at home who do not want to go for treatment, and the family is helpless, even with physical violence very often, right? Now, for this, what we had done in Delhi way back in 2012 was we thought of what is called a mobile mental health unit, MMHU. So, like you have this trend of mobile services for dental, for whole lot of other services, we have conceived in Delhi MMHU way back in 2012, and 2 years ago in 2021, the Delhi High Court and Government of Delhi, we were able to implement MMHU with again one unit, one ambulance with doctor, nurse, counselor in each district. Huh? So this should, in theory, again, and in practice, I guess it happens at least to some extent. Whoever is at home or on the street with severe mental illness, they must be, according to legal process, taken for help. Two, the purpose of this MMHU is also suicide prevention, domestic violence, people who are in emotional crisis. Okay, so the MMHU scheme of Delhi, at least for those of us who happen to be in Delhi, or if you happen to have, this will not apply to NCR townships. You realize those, because NCR townships then get governed by their respective state governments, Haryana, Uttar Pradesh. Okay, but for Delhi, there is by now there is a network of MMHU services, one for each district, and there are telephone lines and email services available at IBAS that any one of us should use and can use. So that's one progressive part. And of course, not to forget, some of us will remember our finance minister nearly 2 years ago announced the Delhi counseling services, right? Massive budget in the union budget. And through Nimesh Bangalore and a whole lot of state mental health institutions, the counseling or Manas services are being implemented. Again, all of you, our medical colleagues, very briefly to bring you updated on that. See, the basic framework that has been worked out in telemana services is, I think, pretty sound. Level one, persons with mental illness and whatever needs to be done. Okay, on the lines that we discussed, of course, with a whole lot of questions that remain still. Second is persons with mental distress. May not be mental disorder, mental illness, but mental distress. Psychological symptoms, problematic, but no disorder. And third, of course, is mental wellness. As you will remember, and many of us will remember, during the epidemic, especially last 2 years, all the three issues became very important, including mental wellness. So again, I think the direction is very good that the telecounseling services being implemented across the country is looking at all three levels. We mental illness, stress, and mental wellness, positive mental health, so to say. Can I also briefly just say that, I know this is not perhaps the forum in terms of right, but I cannot but mention, my friend, again for all of you. See, we all often used to write in school, if you remember the essay, Sound Mind in Sound Body. All generations wrote that essay. In MBBS and all postgraduate specialties also, there is some component of psychology and psychosocial factors. But in actual practice, we all forget that there is a significant overlap and comorbidity between physical and mental health issues. So, like I said, diabetes, IBS, whatever, many of the health conditions actually have significant overlap with depression, anxiety, other mental health problems. And so, other than the core psychiatry or mental health issues that we mental health teams might deal with, what I will really urge all medical colleagues, and we keep trying to get this message across, is keep your eyes and ears open to identifying depression or mental health issues in anybody with physical health issues in the outpatient or in the inpatient. Because what is very crucial, and I don't remember we have discussed this in this platform with you anytime. Sometime maybe we should plan this separately. The comorbidity between physical and mental health. Okay, notably, greatest example, diabetes and depression. But what is very interesting, though, is that 20, 30 years ago there has been data which keeps getting stronger. Not only the depression with diabetes or heart attack or bronchial asthma or any other condition deserves to be treated, but if you handle the mental health problem well, the outcome of the fundamental basic physical health problem becomes much better. Okay. And so identification and treatment of mental health problems coexisting with physical health issues is a huge gap, is a huge need. I would say, as far as to say, is a huge responsibility. And that cannot be done by psychiatrists and only mental health professionals. That will have to be done by all medical colleagues and all health professionals. So I will perhaps utilize this platform and your opportunity given to me to highlight briefly once that please let all health professionals become more and more alert to and we have on their radar identification and management of mental health problems alongside physical health problems.
True. True, sir. We are having shortage of time, sir. I think that we
I
have put
know, I know.
everything in a very brief way about what is actually mental health law, and I think that we will have one more episode in this to cover more
Sure.
about the physical and the mental health issues, where all the healthcare professionals and medical bodies, association, everyone can work for this. And one more upcoming show that I have planned for you and myself is that we will be covering about how psychiatry has grown over a period of time and how much it is now for newcomers to take psychiatry as a branch, and what is its job scopes and everything regarding to the future of psychiatry from you, sir.
And one more thing, if I may mention, Rohan, I know you and your colleagues are very progressive. Uh, Health and mental health issues of physicians.
Yes, health and mental health issues
Okay.
of physics. Okay, sir. I'll note it
Themselves.
down. Yeah.
You, okay. The attitude, the blocks seeking help, both for even
Yes.
physical health problems. So
Okay.
that's a very, very big gap again.
Yes, sir. That is true, sir. Okay,
Yeah.
sir. Thank you so much, sir, for giving your time, sir.
Thank you,
Let's meet
Rohan.
again.
Bye. Thanks
Thank
so
you,
much.
sir.
Good night.
Thanks a lot,
Bye.
sir. Good.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.